Hello everyone. So today we're going to discuss about multiple sclerosis. So multiple sclerosis is a chronic autoimmune and demyelinating disease of the central nervous system, which includes the brain, spinal cord, and optic nerves. In MS, the immune system mistakenly attacks the myelin sheath, the protective layer around the nerve fibers, causing inflammation and damage. This myelin damage disrupts the transmission of nerve signals, leading to a range of neurological symptoms. The exact cause of MS is still unknown, but it is thought to be a combination of genetic, environmental, and possibly viral factors that trigger the immune system's response. Multiple sclerosis primarily affects young adults between the ages of 20 and 40, a pattern observed globally. While the exact reason for this age specific onset isn't fully understood, there are several factors thought to contribute to this trend. Number one, genetic predisposition and environmental triggers. Number two, immune system maturation and behavior changes. Number three, hormonal factors. 4. Delayed diagnosis in adolescents. 5. Interaction between genetics and environmental exposure timing. So, overall, the onset of MS in young adults is likely the result of a complex interplay between genetic susceptibility, environmental triggers, immune system factors, and hormonal influences, all of which tend to converge during this pivotal age range. So, MS is also more common in females than males, with women being 2 to 3 times more likely to develop the disease. This gender disparity is attributed to a combination of genetic, hormonal, and immune related factors, including hormonal influence, genetic susceptibility, immune system differences, environmental and lifestyle factors, changes in MS rates over time. So, the increased prevalence of MS in women is likely due to the combined influence of hormonal, genetic, immune, and environmental factors, which, with hormones and immune system differences being central. Understanding these factors further could help in developing gender specific treatments and prevention strategies for MS. Our MS or multiple sclerosis is known also for its unpredictability and significant variability between individuals due to a combination of genetic, environmental, immune, and lifestyle factors that affect each person differently. So, here's why MS presents so variably. Number one, again, because of the genetic differences. Number two, diverse immune system responses. Three, variable sites of demyelination in the central nervous system. So the central nervous system is vast and MS lesions can occur in any area of the brain, spinal cord, or optic nerves. Symptoms depend on the lesion's location. For instance, lesions in the optic nerve may cause vision issues, while spinal cord lesions may result in motor or sensory problems. Each individual's symptoms profile is influenced by where and how extensively the CNS is affected. Four is the disease subtype. So we'll talk about the different subtypes of MS later. The environmental and lifestyle factors. What are the environmental triggers? Lifestyle choices, which affects MS risk, progression, and severity. So, for example, smoking has been associated with faster disease progression, while higher vitamin D levels may reduce the risk of MS or slow its progression. Six is the hormonal influences, the hormonal fluctuation, especially in women. Seven is response to treatment. MS treatments affect individuals differently, with some patients responding well to certain disease modifying therapies, while others may not. So, treatment response can influence disease progression, the symptom severity, and quality of life, making the course of MS highly individualized. Um, Depends also on the variable progression rates. So, some individuals with MS experience a slow progression with minimal disability over many years, but others may have a more aggressive disease course. So, it's not yet clear why progression rates differ so widely. but it may involve a combination of genetic and environmental factors as well as the disease subtype. Also, psychological and social factors, the emotional well being, the stress levels, social support, and coping mechanisms also affect how individuals experience and manage MS. Stress, for example, has been linked to relapses in some individuals, and mental health can influence disease perception and symptom management, impacting overall quality of life. So, this variability in MS presentation and progression means that each person's journey with the disease is unique, with symptoms, severity, and response to treatment that can change over time. This unpredictability makes MS challenging to manage and necessitates a highly individualized approach to care and treatment. So, again, in summary, the exact cause of multiple sclerosis remains unknown because it is likely a multifactorial disease, meaning it results from a complex interplay of genetic, environmental, immune, and possibly viral factors that differ from one individual to another. So, now let's discuss about the epidemiology of multiple sclerosis. So, the higher prevalence of MS in regions between 40 to 60 degrees latitude likely results from a combination of reduced sunlight exposure, leading to lower vitamin D levels, and environmental exposures during early life, and genetic factors common in these regions. The risk of multiple sclerosis is generally higher in regions situated between 40 to 60 degrees latitude, where lower sunlight exposure can lead to reduced vitamin D levels, a factor that is linked to increased MS risk. Major cities within these latitudes include in North America, Seattle, Washington, Chicago, Illinois, New York City, Boston, Toronto, Canada, Montreal, Canada, Calgary, Canada. In Europe, London, United Kingdom, Paris, France, Berlin, Germany, Amsterdam, Netherlands, Copenhagen, and Stockholm, Sweden, Moscow, Russia, and Dublin. How about in Asia? Beijing, China, Seoul, South Korea, Tokyo, Japan, Istanbul, Turkey, Christchurch, New Zealand. In South America, while South America lies mostly outside the typical 40 to 60 degrees latitude risk zones, they said Buenos Aires, Argentina is near the southern boundary. So, these cities located within or near the 40 to 60 degrees latitude range generally have lower year-round sunlight exposure, which can contribute to vitamin D deficiency and increased MS risk. However, it's essential to note that MS prevalence can vary due to genetic and environmental and other factors even with these regions. So, what latitude is Los Angeles? Los Angeles is located at approximately 34.05 north latitude. This places it outside the higher risk 40 to 60 degrees latitude range, often associated with an increased risk of multiple sclerosis due to lower sunlight exposure and potential vitamin D deficiency. So we're outside the risk between 40 to 60 degrees latitude. Multiple sclerosis has a higher prevalence among white populations, particularly those of Northern European descent, compared to other racial and ethnic groups. So this disparity is likely due to a combination again of genetic, environmental, and geographical factors. So now let's discuss about pathology. So the pathology of multiple sclerosis centers on chronic inflammation within the central nervous system, including the brain, spinal cord, and optic nerves. This inflammation leads to a progressive degeneration of myelin, which is again the protective sheath around nerve fibers, axonal damage, and ultimately neuronal loss. Here's a breakdown of the key pathological processes involved in MS. So number one, there's an autoimmune attack on myelin. So MS is an autoimmune disease where the body's immune system again mistakenly identifies the myelin sheath, a fatty layer that insulates the nerve fibers, as foreign and harmful. So this myelin sheath is critical for fast and efficient nerve signal transmission. In MS, the T cells, which is a type of immune cell, cross the blood-brain barrier, which usually restricts entry of immune cells to protect the central nervous system. Once inside, T cells mistakenly recognize myelin as a target and initiate an inflammatory response. So T cells release cytokines and recruit other immune cells such as B cells and macrophages, amplifying the inflammatory process. B cells produce antibodies against myelin, further damaging it, while macrophages engulf and destroy the damaged myelin. There's also demyelination and formation of lesions or plaques. So this immune attack results in demyelination, where the myelin sheath is stripped from the nerve fibers, which is the axons, leaving them exposed. So without myelin, nerve signal transmission slows down, becomes erratic, or is completely blocked. Areas of concentrated myelin loss and inflammation are called lesions or plaques. Therefore, multiple sclerosis. These plaques are typically visible on magnetic resonance imaging or your MRI and are a hallmark of MS. They can form in various parts of the central nervous system depending on where immune cells infiltrate. Lesions are most common in white matter regions such as the optic nerve, the spinal cord, brainstem, and areas around the ventricles, but can also appear in gray matter. The location of lesions largely determines the symptoms of MS, such as vision problems, motor or sensory deficits, or coordination issues. Another part of the pathology is the axonal damage and neurodegeneration. As MS progresses, axons themselves may become damaged due to prolonged demyelination and exposure to toxic inflammatory mediators. This axonal injury is irreversible and leads to permanent nerve damage and loss of neurological function. With time, the repeated inflammatory cycles and axonal damage lead to neurodegeneration, resulting in brain atrophy or shrinkage and a gradual loss of the central nervous system tissue. So this axonal and neuronal loss is associated with long-term disability and is a significant factor in the progression from relapsing remitting MS, where symptoms come and go, to going to secondary progressive MS, where symptoms worsen steadily. There's also microglial activation and chronic inflammation. So microglia are resident immune cells within the central nervous system that help remove debris and repair damage. However, in MS, they become persistently activated, contributing to chronic inflammation and neurodegeneration. So chronic activation of microglia releases additional pro-inflammatory substances like cytokines and free radicals, which can worsen myelin and axonal damage and perpetuate the inflammatory cycle, especially in later stages of MS. There is also astrogliosis and scar formation. There's also a blood-brain barrier disruption. In MS, the blood-brain barrier, which typically protects the central nervous system from harmful substances, becomes compromised. So this disruption allows immune cells to enter the central nervous system and exacerbate the inflammation. There's also remyelination and failure of repair mechanisms. So in the early stages of MS, the CNS has some ability to repair and to remyelinate damaged nerve fibers, restoring function to some degree. However, as the disease progresses, these repair mechanisms become less effective. There's chronic inflammation and scar formation, impair remyelination, and So repeated damage exhausts the CNS ability to regenerate, leading to more permanent damage and progressive symptoms. So MS is fundamentally a disease of immune mediated inflammation in the central nervous system. It leads to demyelination, axonal injury, and neurodegeneration. So, this complex interplay of immune responses, tissue damage, and failed repair mechanisms underlies the variability and progression of MS symptoms. As the disease advances, inflammation becomes more chronic, leading to irreversible damage and long term disability. So we see here impaired neuronal transmission. So the impaired neuronal transmission is a core consequence of the disease's pathology. This impairment arises from the damage to myelin, the protective sheath around nerve fibers, which disrupts the normal flow of electrical signals along the nerves. So let's take a closer look at how MS affects neuronal transmission. So what's the role of myelin in neuronal transmission? So we know that myelin acts as an insulating layer around axons, which is the long projections of neurons that carry electrical signals. This insulation enables rapid, efficient signal transmission by allowing electrical impulses to jump between gaps in the myelin called your nodes of Ranvier. So, in a healthy nerve, this process known as saltatory conduction allows nerve signals to travel quickly from one node to the next, ensuring efficient communication between different parts of the central nervous system and the body. So, there's demyelination and signal disruption as part also of pathology. So in MS, the immune system mistakenly again attacks the myelin sheath, resulting in demyelination. This myelin loss axons, and the axons are exposed, and it disrupts the saltatory conduction. So without myelin insulation, electrical impulses slow down significantly or may even fail to reach their destination. The nerve transmission becomes less efficient and more vulnerable to interruptions. So, damage or incomplete transmission manifests as neurological symptoms such as muscle weakness, sensory disturbances like your numbness or tingling. There will be coordination issues, vision problems, depending where the demyelinated lesions actually occur. There will also be formation of lesions and conduction block. So the areas of demyelination known as lesions or plaques interrupt signal pathways. So these lesions can block or alter the path of electrical signals. There is also inefficient energy use and axonal fatigue. So demyelinated axons require more energy to transmit signals because they must rely on continuous conduction rather than the saltatory conduction. So this places a heavy metabolic demand on neurons, leading to axonal fatigue, especially with repeated activity. There will be axonal damage and permanent impairment. So chronic inflammation and prolonged demyelination expose axons to further damage, causing axonal degeneration. When axons are damaged or severed, signal transmission becomes permanently impaired, leading to irreversible neurological deficits. There's also abnormal signal conduction and symptoms. So, the disruption of neural transmission causes a variety of symptoms that reflect the type and location of affected nerves. So, some motor symptoms are weakness, spasticity, and poor coordination. When nerves controlling movement are affected. Sensory symptoms, there are numbness, tingling, and abnormal sensations like or we call it paresthesia. It results from damage to sensory pathways. There's also cognitive and emotional symptoms. The lesions in the brain can impact memory, attention, and mood, causing cognitive difficulties and emotional changes. In MS, there's also impaired synaptic transmission. So myelin damage affects not only long-range transmission along axons, but also the timing and coordination of signals reaching synapses. It is the connections between the neurons. So delayed or disrupted timing can affect how well neurons communicate further impairing the central nervous system function. There could be partial recovery and remyelination in MS. So, in early stages, the central nervous system can sometimes repair damaged myelin through remyelination, partially restoring the signal conduction. This can lead to temporary recovery or improvement in symptoms during remission phases. But however, remyelination is often incomplete or insufficient over time, leading to continued progression and a gradual decline in neural transmission quality. So, in summary, impaired neural transmission in MS results from the breakdown of myelin, leading to slower, less efficient, and sometimes blocked nerve signals. This impairment affects movement, your sensation, vision, and cognition, depending on where lesions occur in the central nervous system. The resulting neurological symptoms are often variable and worsen over time as demyelination progresses and axons degenerate, contributing to the chronic disability associated with MS. So, there's also plaque formation, thus the name sclerosis. So, in areas of chronic demyelination and axonal damage, the body attempts to repair and contain the inflammation, resulting in scar tissue or called sclerosis. So, these scars are known as plaques and are visible as hardened areas within the brain and the spinal cord. So, plaques form as a result of astrocyte activation, which is a type of glial cell in the central nervous system, in response to tissue damage. So, astrocytes create a dense fibrous network around the site of inflammation, attempting to contain the damage and prevent further spread. So, plaques are permanent and it disrupts the structure of neural tissue, leading to a permanent loss of function in the affected area. So these sclerotic plaques are a hallmark of multiple sclerosis and are visible on your MRI scans as lesions. So here's just a picture showing what a normal nerve look like, and when there's a saltatory conduction and when the neuronal transmission is impaired because of loss of myelin sheath covering the whole axon. So, what part of the central nervous system areas are typically affected? So, we have the optic nerves, which is one of the first symptoms that MS patients actually experience. So, the optic nerves transmit visual information from the eyes to the brain, and they're often one of the first areas affected in MS, leading to optic neuritis. So, one of the symptoms of optic neuritis is blurred vision, pain with eye movement, there's loss of color vision, or vision loss in one eye are common. Many individuals with MS experience episodes of optic neuritis early in the disease. It can also affect the internal capsule. So this is a white matter structure in the brain that carries motor and sensory fibers between the cerebral cortex and down to the brain stem. It includes fibers for motor control, which is coming from the cortex, which is the corticospinal tract, and sensory information that comes from the thalamic projections. So when there's lesion in the internal capsule, one of their symptoms are lesions. It can lead to motor weakness or hemiparesis, or weakness on one side of the body due to the disruption of motor pathways. They may also affect sensory functions, leading to sensory deficits such as numbness or tingling on one side of the body. So the corticospinal tracts could also be affected. These are major pathways that carry motor signals from the motor cortex in the brain down through the brainstem and spinal cord to control your voluntary muscle movement. So, if there are lesions in this corticospinal tract, it leads to motor dysfunction because these pathways are essential for initiating and coordinating movement. Symptoms of affectation of the corticospinal tracts includes weakness or paralysis in the limbs. There's spasticity, meaning increased muscle tone and reflexes. There's clumsiness and difficulty with fine motor skills. Damage in these tracts typically leads to symptoms that are contralateral or opposite to the lesion if it occurs above the spinal cord level. And you know, your corticospinal tract is an upper motor neuron lesion, which is above your spinal cord. Another area in the CNS that is typically affected is your brainstem tract system. So the brainstem contains several important tract system. These include your medial longitudinal fasciculus, which is involved in coordinating eye movements and head posture. Your spinothalamic tract, remember it carries pain and temperature sensations from the body. Your dorsal column medial lemniscal pathways, another ascending tracts which transmits fine touch and proprioceptive information, which is the sense of body position. So if you have affectation of the brainstem tract system, symptoms would be in the medial longitudinal fasciculus. It can cause internuclear ophthalmoplegia. It's a condition where eye movements are uncoordinated, leading to double vision. There's also damage to the spinothalamic tract, which will result in sensory disturbances such as loss of pain and temperature sensation. So, lesions affecting the dorsal column medial lemniscal pathway, it will cause issues with balance, your proprioception, and fine touch, often resulting in clumsiness or difficulty with precise movements. The cerebellar peduncles, they are bundles of nerve fibers that connect the cerebellum to the brainstem and coordinate movement by relaying information between the two areas, the cerebellum and your brainstem. So lesions in this part of the CNS disrupt the flow of information to and from the cerebellum, which will result in ataxia or loss of coordination. There will be tremors, dysmetria, which is inability to judge distances in movement, and dysdiadochokinesia, which is difficulty with rapid alternating movements. This can manifest as unsteady gait, clumsiness, and difficulty with tasks requiring fine motor control. So, what about the dorsal spinal cord? If this is affected, there will be damage to the dorsal spinal cord in MS will also result in sensory ataxia, where the person has difficulty coordinating movements due to impaired proprioception. As you know, the dorsal spinal cord is responsible for this. So this may lead to issues with balance, a sensation of walking on foam, or difficulty with spatial awareness. So there may also be a loss of fine touch and vibration sense in the affected limbs. So here are some of the clinical features of multiple sclerosis. So in the visual impairments, there's nystagmus, which is an involuntary rhythmic oscillation of the eyes, often described as a shaking or jiggling motion of the eyes. It can occur horizontally, vertically, or in a rotary pattern, depending on the underlying cause and area of the CNS affected. Okay, so there's also your optic neuritis. This is an inflammation of the optic nerve, the nerve responsible for transmitting visual information from the eyes to the brain. It is one of the most common early symptoms of MS and can be a key indicator in diagnosing the disease. So the symptoms of optic neuritis is pain, especially when moving the eye, blurred or dim vision in one eye, loss of color vision, where colors may appear less vibrant, a dark or blind spot called the scotoma in the center of the visual field, and in severe cases, complete vision loss in the affected eye. In central, okay, it could affect it could affect the patient's strength. So there will be fatigue, even their cognition can be affected. There will be depression and unstable mood. In the musculoskeletal system, there's weakness, presence of spasms, ataxia for the gait pattern. For sensation, patient can feel pain. Okay, there could be hyposthesia. So this is known as decreased or diminished sensation. It is a partial loss of sensitivity to touch, temperature, or pain. It can occur in any part of the body depending on where MS lesions are located in the central nervous system. Okay, so there's also paresthesias. So these are abnormal, often uncomfortable sensations such as tingling, pins and needles, burning or prickling that occur without even any external stimulus. So these sensations may be transient or persistent and can affect also any part of the body. Bowel, patient could have incontinence, diarrhea, or constipation. Patient could have urinary incontinence or frequency or retention. Patients' most common symptoms, weakness, spasticity, ataxia, double vision, tremor, and they have intention tremors, fatigue, paresthesias, unsteady gait, bladder and bowel dysfunction. 90% of the time, there's presence of spasticity. It's positive for clonus and positive for Babinski. They have muscle spasms and spastic gait. So you know how to test Babinski and assess clonus. There's also muscle weakness and paralysis. There's slowness of movements. They feel stiff and they get tired easily. So we also have impaired coordination for our patients. So there's dysmetria. Again, it is the inability to control the distance, the speed and range of movements, leading to overshooting or hypermetria or undershooting, or you call it hypometria of intended targets. So it is commonly seen in movements requiring precise coordination, such as when you want to reach for an object. Okay, so there's also what else? Dyssynergia. So dyssynergia is the loss of coordinated muscle activity, where movements that should be smooth and integrated become fragmented and jerky. So in dyssynergia, complex movements break down into smaller and uncoordinated steps. So again, we also have the dysdiadochokinesia. It is the difficulty or inability to perform the rapid alternating movements, such as quickly flipping the hand from palm up to palm down or tapping fingers in succession. It reflects impaired rhythm and timing in motor tasks. So we also have ataxia, which is a general lack of muscle coordination during voluntary movements, often resulting in an unsteady gait, clumsiness, and balance difficulties. So patients also has postural tremors. They have slurred speech and scanning speech and difficulty in swallowing as well. So we talked about scotoma a while ago with some blind spots, okay, or could be total blindness. So the visual defects are generally secondary to the optic neuritis. Okay, there's blurred vision and double vision. So there's also again with the somatosensory impairments, we talk about the different parts of the spinal cord and the medial lemniscal pathway, the dorsal spinal cord that transmits sensory information. So patients with impairments with MS have somatosensory impairments like paresthesias, diesthesias, okay, and they're positive for Lermite sign. So how do we perform this? We have the patient do a maximal neck flexion, and then if there's shooting or electric-like pain in lower extremity, then they're positive for this one. So patient also experiences numbness, musculoskeletal pain, distortion of superficial sensation perception. Okay, so light touch, vibration sense, proprioception, and all that. Patients with MS also experience bowel, bladder, and sexual dysfunction. So approximately 80% of patients experiences this one. They have urinary urgency and frequency, urinary incontinence, urinary retention, and just like Parkinson's, they also have constipation just because of decreased intestinal motility or movement as well. So there's also sexual dysfunction, which is 91% for men and 72% for women. Impotence, diminished genital sensation, and lubrication. How about cognitive and behavioral impairments that can be found in MS? Approximately 50% of patients experience cognitive or behavioral impairments. So there will be mental deterioration and will develop global dementia in the latter stages. They have the euphoria, just extreme feeling, okay. Could be happiness, okay, and then they could be anxious, also depressed, angry, dependent, and could be diagnosed with bipolar problem. So they could have cognitive and emotional symptoms, emotional lability, they're unsteady with their emotions, the judgment could be impaired, there's agnosia, memory disturbance, diminished conceptual thinking, decreased attention and concentration. So it's always harder for patients with MS to actually follow through with therapy because of these cognitive and behavioral impairments. So, how do we actually diagnose MS? There are different diagnostic tests that are available for our patients. So, we have the CSF exam, where they take in the CSF fluid through lumbar puncture. We have also MRI showing plaque formation, CT scan, somatosensory visual or auditory evoked potential examination. They look at the spinal cord. We have the NCV, EEG, and blood test, which will look for the T cell count. So, how do we actually assess the types of MS? So, we have the definition over here. We have the benign multiple sclerosis, which we find no disability, and then will return to normal between attacks, looking at this line, right? So there will be a time of attacks and then it will go back to normal. So the relapsing remitting, it's unpredictable attacks which may possibly leave permanent deficits followed by periods of remission. So even though there's period of remission, you could see as they go back in remission, it doesn't go back to the normal level or to the prior level. We have the primary progressive MS. As you can see the line, there's a steady increase in disability even without the attacks. We have the secondary progressive MS, initial relapsing, remitting, multiple sclerosis, and then suddenly begins to decline without even a period of remission. So you will not see much of the remissions anymore. And then the last one is the progressive relapsing MS, which is a steady decline since disease onset with superimposed attacks. So you can see in this one the increasing disability as time goes by. So how do we rehabilitate patients with multiple sclerosis? So when there's improvement with the function of the patient, this is because of the spontaneous neurologic recovery that's happening within the central nervous system, the intervention through pharmacologic management and rehabilitation interventions. So it's very important that we set up a goal for set up goals for our patients, which is to maintain and improve functional level and independence, prevent secondary impairments. We don't want them to have falls or develop contractures. We don't want them to develop postural abnormality. What else? or just unsteady gait, or we want them to become functional and independent as possible. So we also maintain respiratory function, right? We give them relaxation techniques, breathing exercises. We manage their fatigue and conserve their energy. So when do we provide their therapy session? We provide it at early morning, before they actually do a lot of their ADLs and functional mobility at home, so they could actually participate with therapy. We have to also educate patient and family to maximize the retention of gains. As you could see, there are periods of attacks and periods of remission, and there are attacks without even remissions anymore. So there's, like, you could see sometimes a steady decline with some of our patients, depending on what types of uh, MS do they have. And we need to promote their well-being. As you know, they have a lot of cognitive impairments, emotional labilities, and then other somatosensory impairments. So we have to manage the total aspect of life for all of our patients. So we'll see you in our next topic.